Okay, thank you so much. Thank you for the invitation to be part of this. I'm just assuming you can hear, right?
All good, thank you.
Okay, great, fantastic. And um, really a very important time in RSV, a very exciting time, because for the first time, we are seeing our effective preventive interventions, both in infants and in adults, elderly adults, so-called elderly adults above 60 years of age. I'm not going to focus on the elderly part at all. I'm going to focus on the prevention of RSV, just a quick summary of where we are with these interventions, because RSV is now a preventable disease. So let me try and advance this. So as you'll know, as many of you know, there are two major strategies for preventing RSV in infants. The first is maternal vaccination during pregnancy, and the second is a new long-acting monoclonal antibody. Some of you are familiar with use of palivizumab, short-acting monoclonal. The new monoclonal is nirsevimab. It's a long-acting monoclonal. I'll say a little bit more about that. And I'm going to show you just briefly the efficacy and safety on both of these interventions. Just to say that both of these are at SAPRA currently for approval. So the major data I want to show you on the maternal vaccination trial is the phase 3 study results from Pertussis. These results were published. This is the efficacy, and this is the protection for severe RSV, a lower respiratory tract infection in infants, 90 days after birth up to 180 days of birth. And you'll see at 90 days, it's about 82% protective efficacy, and it drops to about 69% at 180 days. Recently, the final results from this trial were presented with additional data, and you'll see the final results are very, very similar to those published data. And a few points I just want to make. This is the curve of infants born to mothers who either received the vaccine or received placebo from birth through 180 days. And what you can see is that, I don't know why it's not showing up. Yeah, there we go. That from birth, from the time of birth, there is high efficacy against severe disease. And the second point I want to make is that this efficacy is seen even from 5 to 6 months of age, where you see a sort of a 67% incremental vaccine efficacy from 5 to 6 months of age. So the message from and these are the final results, updated results, is that you see efficacy from birth, and it continues through at least through 6 months of age. A second endpoint was medically attended RSV, lower respiratory tract infection, so less severe disease. And again, the same endpoints, 90 to 180 days after birth. And you see the vaccine efficacy is more modest for less severe disease, 57% at 90 days and down to around 51% at 180 days. And for the final analysis, so this is the published data, for the final analysis, you see it's very similar to the published primary result. And again, you see the exact same pattern with efficacy from day one, from birth, and you also see efficacy continuing through 5 to 6 months. Here, a 46% incremental efficacy from 5 to 6 months. So these are really, really very welcome results in terms of the ability to protect against severe and a medically attended RSV, lower respiratory tract infection. And all of you who are at the coalface know that severe disease is most marked under 6 months of age, and particularly in the 2 to 3 month age group. So here we have an intervention that is highly effective for preventing that severe disease. Now, recently, GSK published their results. In fact, this was just a week ago. And you'll know that the GSK vaccine, which is similar to the data I've shown to you, is the Pfizer vaccine. The Pfizer vaccine is a bivalent vaccine against RSV A and B. The GSK is a monovalent vaccine and a different production process, but it's also an RSV pre-F vaccine. And here you see the efficacy for medically attended RSV LRTI, around 65%, and this is up to 6 months, and for severe RSV 69%. So again, a good efficacy in this trial. Now you'll know that this trial was actually discontinued, or some of you will know that it's was discontinued about a third of the way into the study. And I'm going to come back to that, and that was for issues of safety. So I'm sure many of you will have questions about that, and I'll show you the safety data. I just want to show you the long-acting monoclonal antibody data first. This is Nirsevimab, a long-acting monoclonal antibody. It's a single dose given intramuscularly, and it has protective efficacy for at least 6 months as well. And I'm just going to summarize a lot of information. 3 pivotal trials, the first done in preterm infants, 29 to 35 weeks, with a 50 milligram dose, the second in late preterm or full-term babies. And here, what was realized in the first trial was that actually 50 milligrams was inadequate for infants who weighed more than 5 kilograms. So this trial was done with appropriate dosing of 50 or 100 milligrams, depending on weight. And then thirdly, the pooled results by weight dosing and the complete results, which were reported in 2 different publications. And just to highlight that although preterms are more susceptible to severe disease, the largest burden of hospitalization from RSV or severe RSV occurs in full-term infants because they are the majority of the population. So this is a really important group to protect against severe disease that we don't usually think of. And so here is the data in the preterm study. You see an efficacy for medically attended RSV of 70%, and for hospitalizations for more severe disease, close to 80%, highly effective intervention. And this is the combined data for the term and late preterm infants through 150 days. And you see again, efficacy for medically attended RSV about 76%, up to around 79% for very severe RSV LRTI. So very, very effective. Let me just quickly, and the safety, of course, was excellent safety profile. I wanted to spend a few moments on the safety profile of the Pfizer and the GSK vaccines, because this is causing a lot of discussion and a lot of controversy. And so the major issue is around an imbalance in preterm births amongst infants born to mothers in the Pfizer trial whose mothers who were vaccinated versus mothers who received placebo. So you can see it's 5.7% in infants who were born to mothers who got the pre-F vaccine, and 4.7% in infants who were born to mothers who received placebo. And you can see if you look at low birth weight, this difference is reduced. So some of this is misclassification of prematurity by ultrasound, and how gestational age was done in these trials is mostly an ultrasound in the second trimester of pregnancy, which we know can misclassify gestational age by around 2 weeks. So there is some misclassification. Now let's just look at the differences in prematurity. And here you see these are the published data. Premature delivery higher imbalance in mothers who were vaccinated versus mothers who received placebo. But look at this result. SARS-CoV-2 positivity, clearly higher, and I must interpret this with caution because these testing was just done in symptomatic mothers. It wasn't a rigorously done thing, but in mothers who were symptomatic and in whom testing was done, you see higher SARS-CoV-2 rates in mothers who received vaccine than those who received placebo. And why I'm showing you with this is because the data from the Pfizer vaccine, in which there's an imbalance in prematurity, is very closely aligned with the Delta wave in South Africa and in the countries in whom that prematurity was seen. If you look at the time of vaccination of mothers and subsequent premature births, firstly, if you look at premature births here, you will see that 95% of births are 36 weeks or slightly more. So very, very few extremely or very preterm babies. In fact, the median age of premature babies was 36 weeks. And there's no association between the time of vaccination and birth delivery, either prematurely or full term. And in fact, the mean time from vaccination to delivery is around 57 days. So this is very difficult to explain how a vaccination would be associated with prematurity, given that there's no temporal relationship. But what is striking is that this relationship was only seen in low middle income countries and occurred simultaneously with the Delta wave. So some interaction with Delta appears to be a possible reason. Now let's look at the GSK data. And this vaccine trial was stopped because of the imbalance in preterm births. And here you see again, 6.8% in infants whose mothers were vaccinated versus 4.9% in those who received placebo. There's the relative risk ratio. It's significant. Few neonatal deaths, although there were more in the vaccinated group. This is not the same in the Pfizer group. In the Pfizer group, there were only 3 deaths overall, 1 in the vaccinated group and 2 in the placebo group. And again, you will see that the majority of preterm births in the GSK vaccine are late preterm, moderate to late, 224 out of 237 in the vaccinated group and 84 out of 86 in the preterm. The randomization here was 2-to-1. So that's why the numbers are, look so different. But there is a significant association with vaccination with pre-F. And again, the same pattern, only in low middle income countries, no association of timing of vaccination and birth. But, and there's the low middle income country thing, but a striking association of preterm birth with the COVID wave, particularly Delta. And that's what I bring there. So I think, these results have been considered by many regulatory authorities. And in terms of the maternal vaccine, it's now approved and in use in the USA, in the EU, in Argentina, which implemented about a month ago. And our own regulatory body is now considering this. Similarly for Nirsevimab, approved in the US, in the EU, a huge run on this product through their RSV season, and lots of shortages being implemented in Spain, being implemented in France, being implemented in many high-income countries. Chile have just implemented universally for infants born during or before the RSV season, or for high-risk infants who are entering their second season. And I think, we're poised in South Africa to consider both these highly effective interventions for use. I'm going to stop there. I'm sure there are a lot of questions.
Thank you, Heather. That was absolutely amazing. Can you stop sharing? Okay. Right. So I do see one of the questions that was in the chat was actually answered. There's a question saying, at what gestation would pregnant women be vaccinated? And
yeah, so this is not straightforward, right? The Pfizer trial was done from enrolled women 24 to 36 weeks of age, and similarly the GSK trial. Because of this imbalance in prematurity, the FDA recommended administration only from 32 weeks onwards. Argentina has implemented from 32 weeks onwards. However, the EU has implemented from 28 weeks onwards. I think from 24 weeks onwards. Sorry, I'm just a little, I'm blanking on whether it's 24 or 28 weeks, but it's earlier. The reality is that if you look at age of gestational age at vaccination and risk of prematurity, in fact, in the GSK vaccine, and maybe I can go back to the last, my very last slide, if there's time, the highest risk was in, let me just go there, sorry. I don't think you can see it. The highest risk was in women vaccinated after 28 weeks of pregnancy, not earlier. Just let me show you. I don't know if you can see that. Sorry. Oh, it's gone. It's got a life of its own, this thing. Can you see that?
Mm-hmm. Yeah.
And if you just look at that last red bar, in fact, the highest risk and significant risk was in women who were vaccinated after 29 weeks of pregnancy. So it's not clear that vaccinating earlier is more associated with prematurity. Of course, if you vaccinate later, the chances of having a premature baby are less because there's less time to go in pregnancy. But it would be very hard, I think, to implement in our setting a very restricted gestational age for vaccination of 32 to 36 weeks. The other data that I haven't shown is the immunogenicity data that actually shows that if you vaccinate, if you allow that this protection for 6 months occurs as long as vaccination occurs within 2 weeks or more. So you need 2 weeks of time for transplacental transfer. However, amongst infants who were vaccinated in which there was less than 2 weeks of time for transplacental transfer, the protection was around 3 months. So
okay, so that answers Avani's question also. How soon before delivery does vaccination need to be done for best efficacy?
Best efficacy more than 2 weeks, but even within 2 weeks, you get some protection up to 3 months because you get very high maternal levels of antibody from this vaccination.
Okay. All right, awesome. I'm going to take one more question here regarding the vaccine, and then we'll start with some of our other questions. Are trials ongoing in relation to the preterm safety signal, or is it being monitored post-marketing only?
Yeah, so there's a lot of post-marketing surveillance in the States, in the EU, in Argentina. I mean, Argentina have not enrolled, but have vaccinated like 20,000 women in the last month. You know, it's a very huge population. So we will have good data. There is 2 trials that will be on, there's a trial that will be started, which is called the IMPACT trial. It's a trial that WHO asked for and it's funded by the Gates Foundation. And it will be a trial to look at safety, but also to look at the broader public health impact, which I haven't gone into, like protection against non-RSV LRTI, protection against recurrent wheezing and so on. And there's currently what has just started in South Africa. It's an immunogenicity trial largely in HIV infected women. And it's 1 dose. I see there's one question, how many doses? A single dose. All of these interventions are a single dose, nirsevimab or the vaccine.
Okay, that's absolutely wonderful. Thank you so much. I think we're going to move on to our questions. I'm going to start off. I'm sure we're going to get back to a lot of questions regarding the RSV vaccine. But if we can get going with some of the other stuff, Heather, still with you, what can we actually expect from RSV this season?
So, I mean, I think we've seen pretty much a return to normal, to pre-COVID levels. You know, we're not expecting a huge spike, as was seen immediately after COVID in some areas, although South Africa didn't experience actually the same kind of peaks that other places did. And I think we're basically expecting the usual season.
Okay,
We've started in the Western Cape. Around 20% of our isolates are RSV positive currently. Of course, Gauteng precedes us. Charl can say more about that. But I know that their season has happened.
Yeah, we've started about 2 weeks ago with more than 10% of all our samples positive. And what's interesting is the majority, I don't know if it's the same with you, Heather, but the majority of our samples are RSV B positive at the moment. We haven't seen that many RSVAs. So just a bit different from last year where it was more a mixed and more RSVA.
Thank you, everyone. Thank you, Professor. I think there are going to be so many questions about the vaccine. So I think this is partly something that you have answered already. But I think importantly, because you said we are starting to consider the vaccine in South Africa, but where are we with the vaccine and what is happening in South Africa specifically with introducing it here? Because I think it'll make a massive difference to what we see in our pediatric wards and ICUs.
Yeah, it will. And I haven't showed you the data of implementation in some countries and how this season the number of admissions have just plummeted. And you talk to pediatricians like in Spain, Galicia, where they implemented Nirsevimab University, and they tell you the wards are empty. So it's a really important question, and it's this frustration of having two effective interventions that we don't yet have access to. So my understanding is that Pfizer submitted to SAPRA sometime last year, and are expecting an answer within the next 2 months, hopefully. For Nirsevimab, it was also submitted a little bit later than Pfizer, so probably SAPRA will take a little bit longer with that. It's going to be too late for this season, but I think we really, for next season, it would be amazing to have both these products available. Getting them out to into the public immunization program is, of course, a whole different issue, because there the resources, the implementation, etc., have to be considered. Another thing that is being worked on is a multi-dose vial for the maternal vaccine, which will make it less expensive, but that's also going to take another 1 to 2 years. But I would urge all of us to really do whatever we can to try and fast track these processes.
Heather, do you perhaps have a estimated price that we might be looking at for something like Nirsevimab?
So I don't know. I mean, of course, the worry with Nirsevimab has always been that it's cost. So my understanding is, for example, in the United States, it's close to around $450 for a single dose. I know that Chile negotiated an almost 50% or more reduction in that price for their population. 2 things. One is actually Cheryl Cohen's group has done very nice work on cost efficacy, and have shown that even at $120 a dose, which seems a huge amount for South Africa, this is cost effective. And at lower amounts, it's cost saving. And the second thing I want to say is there is another long-acting monoclonal antibody, Clesrovimab, that is just completing phase 3. It's completed phase 3 in healthy and preterm infants. It's completing phase 3 in high-risk infants, so those with chronic lung disease or severely preterm or congenital heart disease. And that's going to be competition. And I think, that may also bring prices down. And then the Gates Foundation themselves are working on developing a long-acting monoclonal antibody, but this will take time.
Sorry, Heather, I was just about to reflect in terms of the vaccine timelines and where we are right now. Heather is in the working group that we have at the National Advisory Group for Immunization, because we preempted the availability of the vaccine by already having an advisory, which also benefits in the private sector if there is a formal advisory, because the funders do respond to a formal advisory in terms of what they will fund and what they will not fund. The last time I checked, which was in the beginning of this month, there was actually, I think, still in intention from the manufacturer in terms of registering, but there was nothing in place in terms of this. There is an effort from WHO, because WHO has marked this as a priority vaccine, in particular for low and middle income countries, where more than 90% of the deaths due to RSV actually occur. And with that in mind, the hope is that we could actually, from national advisory in terms of like NAGI, work already with SAPRA to try accelerate that, because you don't only have to wait for a manufacturer to come and apply for a license. You can actually approach a manufacturer and ask them to submit an application because you've prioritized it. And I think that may very well be what we need to do. And we have already had previous meetings with other vaccines with SAPRA to try identify what we need to, and this one will be one of those, hopefully, as well.
Can I ask you, Rudzani, when it was COVID, SAPRA sent quite a bit of stuff to SAPRA with regards to COVID vaccines for special groups of children. So can we not assist? I'm talking about SAPRA and all the pediatricians in SAPRA assist in this process as well.
You can. I mean, part of what SAPA submitted, for example, in terms of vulnerable groups came through the Ministerial Advisory Committee, and I took it in because
Wonderful.
taking the mandate of doing so. So we can actually do that. But specifically, Nagi, and I have reached out, for example, to the CEO of SAPRA to just see if we can continue with conversations that we've had before in terms of anticipating a product that we believe will make immense impact on public on public health, and then try to see how you can then get cooperation from the manufacturer to actually get it registered as soon as possible. And there's a lot of work going on to try make the process much simpler. And we've learned that from COVID that we need to kind of find ways of making that more optimal and efficient.
So just to clarify, both manufacturers have applied for registration, which requires approval of SAPRA. And I think if SAPA were to send a letter saying, look, we're in the middle of the RSV season, once again, our hospitals are overburdened. We see what's happening in high-income countries in terms of the reduction of cases and the potential impact on mortality and morbidity, and we urge SAPRA to move as fast as possible in approval of these products for registration. I think that would be good. I think we need to do whatever advocacy we can.
Perfect. We're definitely going to get onto that. So because we don't have the vaccine now, or the monoclonal, well, we do have some, but what can we do to prevent the surge this season, Heather, or anyone on the panel?
So I think because there's a question about palivizumab as well, right? And
Yes.
and palivizumab is approved, as you know, for high risk
Yes.
premature infants with chronic lung disease, etc., etc. Now, the good news is that the manufacturers of palivizumab tell me that they have now negotiated a public price for this product, and that it's going to be much more widely available and much more affordable. I don't know much more than the details of this, but you know, that is good to know in the interim. Of course, that is only it's several injections, one a month through the RSV season, and it will still be, I presume, you know, at a fair cost, but it may make that more accessible to some really vulnerable infants. What we saw.
If I can jump in about the price quickly, because we have been approached at Baragwana, and the price they've offered it to government is about a third of the price that it's a bit less than a third of the price that it's available now in for private medical patients. So it's still a bit, but it's quite a lot cheaper than it was before the time. So they are obviously, because nirsevimab is coming out, they are trying to push that product at the moment.
Yeah, they're going to do a whole campaign, I understand. But I just want to remind people that in COVID, we saw complete disappearance of RSV, right? And so what were the effective interventions there that we did? And a lot of that was around social distancing, closure of schools, wearing masks, interrupting transmission. Now, I'm not suggesting that we go back to that, but it does speak to the importance of interventions like hand washing, and like, not sending your child to school if they're sick, or potentially people who are sick, staying or keeping away from vulnerable infants and from vulnerable elderly. And the part I haven't said is that Pfizer's applied for registration for this product, not only for infants, but also for the elderly, for 60 and above, where it's also highly effective and where we're recognizing an increasing burden. So yeah, I mean, I think it's these measures, of course, are imperfect, and we don't know which of these measures specifically drove down RSV, but I think the general measures of distancing, hygiene, and so on. The other important thing is to keep other vaccinations up to date, because we know that if you give a child 3 pneumococcal conjugate vaccine doses, there's a much reduced subsequent rate of hospitalization for RSV. And this is because of the interaction, the RSV pneumococcal interaction. So just ensuring also that all children are very well immunized, attention to nutrition, minimizing environmental exposures that are harmful, the usual things that I think that are generic to prevention of lower respiratory tract infection. Charl, I don't know, you may want to say more.
I think it's a lot of the common childhood vaccinations are against lower respiratory tract infective causative organisms, and I think if we just keep them up to date, we can really get the numbers of LRTIs down, and they all have a kind of wave effect on each other. So I think it is important to maintain the lung health in general, so we get less severe disease.
Thank you. I think we can look forward to a lot of exciting things that should be coming to South Africa, hopefully sooner rather than later. I do want to ask a few questions that I think might help our group of listeners with our current surge season. But what is our best management for RSV pneumonia? And I'm just going to bundle a few questions together. So what is the best management for RSV pneumonia? And should we be giving any antibiotics when we just suspect this? And how common is co-infection? I suppose Charl or Prof. Heather can answer.
Yeah, Heather, if you don't mind, I'll talk about this one. I think the global guidelines and South African guidelines and most papers will all agree at the moment that really the only treatment for RSV bronchiolitis is supportive measurements, supportive measures. And with that, we mostly mean oxygen and nutritional support. And if you have to give oxygen via nasal prongs or via high flow nasal cannula, that's basically the only thing that's really going to be helpful pre-ventilation. In a time like now, when we know it's RSV disease, as Heather said, more than 20% of the samples are RSV positive. And if a child presents like a bronchiolitis in the RSV season, it's RSV most likely. And to give any other treatments, it's never been shown really to have much of an impact. And to give antibiotics for those patients is also not helpful at all. Having said that, one of the indications for giving antibiotics in children with RSV is severe disease. So if you're heading towards high frequency nasal not high frequency, sorry, high flow nasal cannula, high flow, and ventilation, yes, then you might have a larger chance of co-infections. You should probably give antibiotics then. But in no other cases is there really any indication for any type or any other kind of medication except for oxygen and nutritional support. Having said that, we're talking now in the RSV season. It's much more difficult outside of the RSV season. When, to the tail end, the beginning and the end of the season, we have children come in with low respiratory tract infections. But I think it's important to realize that in RSV season, antibiotics are not indicated with children. Typical children would come in with hyperinflation. No antibiotics indicated. But if they're very severely ill, I think you're safe to give antibiotics. I mean, that was the short answer. I can go through all the individuals now of nebulizations and adrenaline and steroids and magnesium sulfate. And those are not indicated at all for children with the RSV bronchiolitis.
Yeah, so I think that's great, Charl. I think I think that's important. Everybody, I think, gets really panicky and tries to throw everything at these children, but we know where the evidence is. And definitely, if you've got high flow available, that works absolutely amazing. The humidity, and we've managed to keep a lot of children off the ventilator with the high flow, and sometimes that's
made probably the biggest impact at Barra to the children having easy access to high flow. I think we've kept the ICU numbers down quite nicely, and to realize that you must initiate early if possible. No, it's not a treatment because you don't have an ICU bed and you don't have invasive ventilation. It's a treatment it's not a bridging treatment. It's actually the treatment of choice. So I think that would be very helpful if you do have it, but to start it a bit earlier would probably you wouldn't be going amiss.
And then in terms of, I see there's a question, best treatment for the fever in bronchiolitis? Paracetamol?
Good old-fashioned paracetamol. Nothing wrong with it.
Nothing wrong with Panado. It's the
Nothing
GP's choice.
Wrong.
And then, is there anything we can do to prevent complications like a BOOP, bronchiolitis obliterans, organized pneumonia? Heather, Charl?
No, I mean, we can't, if you have a patient with adenoviral bronchiolitis or LRTI that's very sick, you've got a better predictive index of developing post-infectious bronchiolitis obliterans. For RSV, you can't guess, especially in the acute stage. If you start having a child who ends up on invasive ventilation and on high frequency ventilation and prolonged ventilatory strategies, yes, then you've probably got a bigger chance that you might be developing that. But in your average child, you can't guess before the time who's going to develop that. And just on a note there's a question about physiotherapy. And physiotherapy is not indicated in bronchiolitis. In some studies, it's actually shown to be counterproductive, or I wouldn't say harmful, but it's not indicated for children with bronchiolitis. If you have lobar collapses, anything like that, yes, it might help, but not in a child with your basic bronchiolitis.
Yeah, and just from an ICU point of view, when a child's having a bronchospasm, you don't want to physio them, because that's just going to make it all worse.
No. And there's another question about the CRP of 40. If you look at some guidelines, they say that that's probably the cutoff where you're more likely to have bacterial infection towards, and if it's under 40, less likely. But that's also a rule of thumb, really. I would go for more severity. If you have a child, once again, still with hyperinflation and crackles, I still wouldn't go with antibiotics. But the CRP is pushing 40 and higher, you're probably more likely to be dealing with an infection. I generally don't do CRPs in children with bronchiolitis, so I wouldn't be able to comment on your obvious bronchiolitis with a high, But if you have a high CRP, it's more likely not to be a bronchiolitis, but a bronchopneumonia or, So, but I wouldn't do CRPs in your basic children with bronchiolitis.
And then Charl, because we want to get onto the pertussis and hear Rudzani's voice. One of the questions that I see there, and it's quite a good question, is the sort of the ex-prems, and some of them have a bit of chronic lung and low-dose steroids. Would you consider that in these kind of patients when they get RSV?
No, it's never been shown to really be helpful, especially in children with chronic lung disease of infancy, old BPDs. It's not been shown to be helpful at all. I know a lot of people like nebulizing budesonide or like giving IV hydrochloride. It hasn't been shown to help in children who are just straightforward bronchiolitis, irrespective of whether they have chronic underlying lung disease or not.
And then the place of dexamethasone in peds ICU for severe RDS. So
I'll leave that one to you.
Yeah, so yes, so by definition, in terms of ARDS, so obviously you have to fulfill criteria, the criteria of ARDS, and then it depends where you are in terms of the ARDS. There is some evidence in terms of using some steroids, but what we're talking about here, I think, is the patient before that. So the RSV bronchiolitis that comes to your ward, and most of the times you can prevent by putting them onto a bit of high flow oxygen. But if they land up in ICU on a ventilator and an oscillator, and you have to find with oxygen indices that are very high in terms of ARDS, then you need to be having the discussions. But then by that stage, you've usually got a secondary bacterial infection, a serious response. There's a whole lot of other stuff, but yes, you can then consider steroids. Okay.
I'll just add one
yes,
comment
go,
on use of antibiotics. And I would say I agree with everything that's been said, but I would say that there is a lot of evidence for pneumococcal RSV interactions in severe disease. And so, I wouldn't be too cavalier with withholding antibiotics in a child who's severely ill. And especially if they've got evidence on X-ray of alveolar consolidation. Because there's lots of evidence now from the pneumococcal trials that reduced RSV, from the RSV trials, from COVID actually, where RSV disappeared. What also happened is pneumococcal disease and alveolar pneumonia disappeared. So there is clearly an interaction, especially with severe disease. And so just be a little bit cautious, especially in a child who may have underlying vulnerability.
Yeah, and I think the guidelines also say in severe disease, please do give antibiotics. But for your run-of-the-mill patient, there's no room for it. I agree completely.
Okay, so I think we're going to move on to some pertussis discussion. I see our panelists are trying to answer as much as they can, and I'm loving the fact that the chat and the Q&A is going. So we are trying to answer as much as we can there, but we're going to start on a bit of pertussis. And if I think all pediatricians have seen children with pertussis, and it's exceptionally scary. Myself and ICU have seen children die from pertussis that are too young to get vaccinated. And so this is something that is very important for our community. Last year, I gave a talk to obstetricians and gynecologists with regards to vaccinating, and I'm sure Ruds will tell us more about this, but I must tell you the majority of private obstetricians and gynecologists were flabbergasted when I told them they could vaccinate their mothers with pertussis vaccine, so that the children, and they were flabbergasted that the children die from pertussis. This came from one of the profs. So we have a lot to do with that. As pediatricians, we need to also try and prevent pertussis and see how we can manage it. So I'm going to hand over to Ruds' first question. What can we expect from pertussis this winter season? Although it feels like we've seen pertussis throughout the summer. Rudzani and Charl. Ruds?
So there are a few studies that people have published now and then that will show a large burden of pertussis at certain times of the year. But by and large, there is no real seasonal pattern to pertussis. I think what usually increases the number seasonally is because of the number of samples tested, and those will be related to general respiratory disease during certain months of the year. So it will then show a large number, but if you do as a proportion of specimens sent, you actually almost see the same level throughout. What you should expect from pertussis, generally speaking, is not so much a seasonal pattern as much as a cyclical pattern, because it relates to, if you see even when vaccination started, you'll see this pattern of almost like a pattern that goes, even when the cases became fewer, you still had the cycling. It may become longer, and the peaks may become smaller depending on the level of coverage. But as soon as you start accumulating susceptibles, either with both new children being born, waning immunity, and so forth, you will get to a level where the threshold of another outbreak will come through. We've just come from one in end of 2022, beginning of 2023, that was really horrible, and in particular in the Western Cape, where we were taking those cases. There were 12 deaths here in the Western Cape, which is quite terrible, and virtually all of them were less than 2 months of age. So I wouldn't necessarily expect another huge peak per se, but the individual patients that you'll get, given that we are still struggling with meaningful vaccine coverage still in everywhere in the country, and that we are only starting now with vaccinating in pregnancy, which has now been rolled out in the national immunization schedule. So pregnant women, the tetanus vaccine is being replaced with Tdap, and that actually is probably the only way to stop young infants from getting pertussis. When Argentina introduced it in 2012, after having a terrible outbreak with death in 2011, they basically switched off the deaths, and you're right, Espina, the problem is that those who are in a position of intervention, they don't carry the burden of the disease. We do. And there are so many of these meetings where you speak to pediatricians. You're basically preaching to the converted, preaching to the choir. And the question, what we really need is to have more midwives, more generalists, and as well as obstetricians listening to this message and owning that space. That's the only thing that will make a difference. In fact, the dose in pregnancy is probably much more important than the dose in the second year of life. So you need the primary schedule, your 6, 10, 14. But that birth dose, I suspect, may be the most important dose of even those ones, because almost all the deaths will occur before 6 months of age. And for pertussis, you really don't become meaningfully immune until you have finished your primary schedule, for a very good reason that I probably can't go into now, that comes from the 1920s and 1930s.
That's brilliant.
No,
Go, Shagan.
Yeah, I think for the kids with pertussis that are coming through to the ICU, they often have such severe disease that, gives you sleepless nights. So I'm glad that, it is being rolled out to pregnant women to try and limit this with what we are seeing. And I'm sure, Despina, in your unit, you're seeing them as well. I think just more of a practical thing is often when we get these kiddos, we send off their tracheal aspirates for their PCRs to try and get their pertussis screening back. And often the kids make it out of the unit and into a normal ward and potentially discharged before that result comes. So maybe our panel can help us. So how would us, for all our listeners, how can you take us through a clinical diagnostic approach of when to treat as a suspected pertussis? And should we all notify these cases as soon as we think about it? Because I can tell you in our pediatric ICU at Tygerberg, as soon as the kiddos are started on treatment and suspected, we do notify them prior to getting the results. That's to Charl or Rudzani.
So, Charl, do you want me to answer that?
No, go ahead, Lutz. Go ahead.
So, the clinical case definition of pertussis is very difficult. There have been papers, probably the best one known is one done by Jamie Cherry in 2012, for example, which was in CID, where they tried to propose a different kind of clinical case definition and algorithm for diagnosis. The reality is it really doesn't matter what people come up with. Pertussis is so difficult using a clinical case definition. The one time where you get better sensitivity and specificity is during an outbreak, for obvious reasons that you get a higher positive predictive value just because the disease burden is so high within the community. So that's why, from a WHO point of view, the first diagnostic criteria for pertussis is any case that a clinician thinks is pertussis. That is basically that, and you should take it that way. But in short, if you're going to get a child with severe respiratory disease, even if they don't have paroxysms, especially if they are small and they're having apneas, and there is no fever or low-grade fever, pertussis goes very high in that level, and that's quite important. Most of the respiratory infections, even RSV, may end up with some kind of low-grade fever. Pertussis is one of those where you just don't have fever. If the mother tells you that the baby is vomiting, especially, ask specifically when that vomiting is actually occurring, because quite often people think it's just vomiting, but you'll see that it doesn't typically occur after feeding, which is what you get with gastrointestinal issues. You're gonna get that after coughing, even if that coughing is not paroxysmal. So asking for that in a child with low-grade fever means that you should have a higher index of suspicion. And the reason is simply that when in a community where there's some degree of immunization and some residual immunity, partial immunity alters the classical picture of pertussis, except in outbreaks, because there's so many cases that will then present classical like pertussis. And you don't need a laboratory diagnosis and a confirmation to actually notify pertussis, especially if you don't have a better explanation for the respiratory illness. Pertussis may very well be that. And don't be fooled by the duration of cough. I mean, when we did a study here in Cape Town, our average hospital duration of coughing at the time when we diagnosed most of the cases, it was about 5 days. In fact, the majority were diagnosed before 7 days of coughing. So time is out. Don't count the 14 days that WHO used to talk about. If you worry about pertussis and you were going to use antibiotics, you probably may be better off using a macrolide, as opposed to using a penicillin if you need to worry about it in that stage, because it will have some impact in terms of transmission and shortening the duration of symptoms. So let me stop here, otherwise I can go on and on.
So what is the actual best test to do though, Rudzani?
If you want to do laboratory diagnosis, it depends when you are actually suspecting pertussis. The most sensitive and early diagnosis is probably using PCR. Culture is really not that great. It is becoming important to worry about culture in the sense that we probably need more and more antibiotic sensitivities. The areas of China and including northern parts of Vietnam have started showing mutation strains that are actually macrolide resistant. So that becomes important for us to start watching for that. But PCR is probably the best test in the first 2 weeks. After that, by the time you go to the 3rd week, if you're having an ongoing cough, it starts falling off. And serology may be of some use. The problem with serology for us is that it's based on responses to pertussis toxin, which is also the main ingredient in all of our vaccines, both whole cell and acellular. So you can't distinguish between antibodies due to the vaccine that they may have received and infection, unless you do paired serology and watch a 4-fold rise in titers, which usually does not help with management. It only helps you in terms of surveillance of confirming that. In older children, of course, if they're coughing, like a 4-year-old or a 5-year-old who was not vaccinated since they were like 18 months, which is in our current schedule, then you can get away with a single serological test, because the antibodies drop so quickly following vaccination with pertussis vaccine that when you get higher titers, the only explanation is infection, not due to the vaccine, if they are like a year since their last dose of pertussis vaccine.
Great, thank you.
So I think you touched on this about resistance to the disease, but which macrolide is the best agent, and does it have any difference to disease process in the patient, or is it all about primary prevention and limiting the spread?
So all macrolides work. I mean, your erythromycin, clarithromycin, and azithromycin. The difference is that the newer ones, clarithromycin and erythromycin, they've got a much higher serum concentration. But what is more important, especially with the azithromycin, is a so-called tissue serum ratio, which is very, very high. Remember, and again, it's important for us when we deal with pertussis, because it's so different from most of the organisms that cause respiratory disease. Virtually all the disease you get from pertussis is non-invasive. It's all due to the toxin effect. Pertussis produces more than 20 toxins. And the most important one is the so-called pertussis toxin, PT. And because of that, you really want a high tissue level that will basically clear it from the epithelium. And azithromycin is much better than all of the other ones because of what it does in terms of that ratio, where you can most patients at normal doses, but within 3 to 5 days, they will virtually have no bacteria left. Unfortunately, because the toxin remains, it means the symptoms can still continue for a much longer period of time, but there's some evidence that shows that it will reduce the duration of those symptoms because you don't have ongoing toxemia going from the side, and will definitely make a huge impact in terms of transmission. So that is basically what you have here.
I think, Rudzani, it's also just important to mention that some of the older macrolides, like erythromycin, has been associated with pyloric stenosis. So if you're going to, there's some recommendations that if you treat children under 2 months for pertussis, you should probably use azithromycin, because the chance is less of developing the hypertrophic pyloric stenosis. Azithro is probably recommended for those children more. And if you can't do that, then even something like Bactrim could have some efficacy in the younger children.
Yep.
And that's excellent. And what is the actual, just remind us the contact precautions, especially in some hospitals where we don't have isolations?
Well, you need isolation in those hospitals.
Yeah.
So
same for RSV.
So just remember this, that pertussis is probably the most infectious bacterial pathogen in terms of its ability to transmit. I mean,
yeah,
its rate of reproduction, your so-called R0, is as close to that of measles. So you're sitting at 12 to 17, 12 to 18, depending on the context. So it's really highly infectious with respect to that. And it's both within households and in hospital. The last outbreak that we saw here, number of those neonates that got infected, it was in a neonatal unit because a mother had pertussis and you ended up with that. So you really need that kind of general sort of infection precautions that are to do with droplet spread and so forth. So if you can, you really want to isolate. In an outbreak, you want to nest all of them in the same ward, for example, isolated from the other patients. And then also what about giving prophylaxis to them, to the staff members looking after them, and even other family members, or even other people who would have been in contact with them. But it's really, really difficult to have any meaningful intervention without being able to implement those because of the infectiousness of pertussis.
So who would get the prophylaxis? Would that be the staff? Would that be the physios, the doctors, the parents?
Ideally, what we should be doing, we should basically be getting all staff
Vaccinated.
members vaccinated, right? And it does help, especially if you are at high risk of having severe respiratory disease, the people, older staff members and so forth, to vaccinate them. But those who have been in contact with the patient within a room over like a couple of hours, they are at risk, especially if they're going to have ongoing contact with the patient. At home, virtually all household members should be seen as being at risk. And the reason why it matters is that they themselves may transmit, and it's possible to actually have asymptomatic spread, because partial immunity can reduce the obvious symptoms, especially in older people, but still be able to have the ability to transmit. So, yep, it's virtually anyone who's been in contact with a patient is in that space for a meaningful period of time should be seen as being at risk.
I think I have one more question from our pre-formed questions that we've just planned just for our Q&A before we start tackling the questions that our participants have. And thank you for everyone for hanging around and giving us your time. So we just want to talk about the severe fulminant cases of malignant pertussis, and barring supportive management with ventilation and fluid management, is there anything else that evidence has shown to improve the outcomes in these kiddos? I mean, the very risky exchange transfusions in these kids, risks and benefits, using nitric oxide or anything else for leukoreduction when these kids are sitting with these tremendously high white cell counts.
If you look at most of the literature on malignant pertussis, it's got a very high mortality rate, usually between 40 and 60% has been reported. And the more sick the child is, or the smaller the child is, the more comorbid diseases the child has, the worse the outcome usually is. There has been probably the best indicator of requiring or developing malignant pertussis would be the white cell count. And they've used a cutoff of about 50,000 per microliter of white cells. Most of the studies that I've been looking at, and Ruth, you can jump in here as well, is the earlier, if you're going to do an exchange transfusion, which is probably the treatment you should be doing for the very severe cases, the only time it's going to help is if you do it early enough. So if you do it before they develop pulmonary hypertension, and if you do it before they develop the multi-organ failure, most of the cases where you do it after that has shown to have a very high mortality rate. So that's the problem. There are risky procedures, especially in acutely ill children, but you have to try to get them early, because they're not just about what we think it's hemodiluting the blood because the white cells are so high. It's also moving the toxoid, the toxin that Ruth was talking about. So it's the dual approach almost. So they do help, and it would be full or even double volume exchange transfusions, but they are risky, but probably a little bit helpful if you do it before the time, a bit earlier, because as soon as they develop the severe complications, it's usually a very poor outcome in these children. And Ruth, I don't know if you want to comment more on that.
Yeah, no, it's probably the very same thing that I was going to say, Charl. The high white cell count is a predictor of mortality. And I think if this helps people in terms of just understanding science, is to remember that lymphocytes are not blood cells per se. They're actually tissue cells. They use the blood stream to go to the site of the tissue where they're supposed to be. And the pertussis toxin make them to stop attaching to the endothelium, which they need in terms of migration to going to the site that they need to go to. And whether that is pertussis' way of protecting itself from them coming to the lungs and recruiting immunity against it or not, that may very well be the case. is that the higher that white cell count is, the higher the level of your pertussis toxin in the blood to induce that kind of endothelial detachment that you then measure with the very high lymphocyte count. That is why even when you look under a microscope, they don't look normal, because they are probably not so much infection responding as much as inactivated lymphocytes that have just fallen off their hold in the endothelium. And so people had thought before by doing exchange transfusion that we're doing is you are actually doing leukodepletion. But what you just said now, Charl, is probably the case, because the thing that kills children with pertussis is probably the pertussis toxin. And by doing exchange transfusion, you're actually getting rid of the toxin, which is the main agent of death, especially in young children. The earlier you do it, the better, because for that reason, because it means the disease is progressing all the time. The difficulty is that people would always try to avoid this more aggressive intervention, and you'll try everything else. And by the time you try that, it's generally too late. And that's been shown that whatever it is, where there is an impact, is when people see a very elevated white cell count in a sick baby, and then go ahead immediately. That's when you get any positive results.
Thank you. And there's a lot of questions relating to a cough, to managing the cough in pertussis. So Charl, tell me what you suggest.
I feel like I've got I get the stick end of the questions now. I mean, yeah, good luck.
We give the science to Heather. We ask you what the pediatrician at the bedside at midnight wants to know.
Yeah, look, it's an extremely different thing. And what people must realize with the cough is, I mean, we've all had cases where children basically cough themselves into hypoxia and into pulmonary hemorrhage and into hypoxic ischemic brain damage because the SATs drop so low. So for the simple cough, you can try things like a little bit of codeine containing medication. It's probably not going to be effective, let me be honest. Because with pertussis, there's also an enhancement of the receptors around the larynx that causes the problem. And these are not going to be, they're not going to be treated by your general cough mixtures. So yes, no, you're not going to be able to manage. I see Rudzani's laughing. You're not going to be able to treat the normal cough very easily. Another question is when the cough becomes... Another question is when the cough becomes so severe that you start getting severe desaturations and severe issues. Probably a better approach for me then would be intubation and paralyzation. If you really have to stop the cough, then actually trying to give medication that's going to try to suppress it, which is probably not going to be helpful. Roots, please.
Nothing works. All evidence in terms of systematic reviews. There was a very lovely one from years ago in Cochrane, and I've seen another one. Nothing has been shown to work. I can tell you anecdotally, and I'm not sure how much I should mention the anecdotal stuff. Some of you will remember and know the late Prof. Max Klein, for example. What he used to suggest, and we've done that, was using chlorpromazine, where he will start them at a dose of sort of 2 milligrams per kilo and increase that up to 8 milligrams per kilo until it reaches a dose that the cough stops. Then that becomes a daily dose for almost the next month until the symptoms resolve. And I've not seen any trials. There is no written stuff on it, but I have used it myself because I'd called him when I was stuck, where the children were coughing themselves blue and they were not basically breathing. And again, just to note that one of the risks that you need to remember is that it's of pneumothorax in these kids. In fact, if you ever have a child with a spontaneous pneumothorax, not sure why, look for pertussis because that may be the reason. And that's one thing that has been described even with the patient, the series of patients from Bloemfontein. But all the other stuff that has been tried before, none of it has actually been shown to actually work with respect to stopping the cough. The best way is to not get pertussis, it seems.
Yeah, I agree. But there was some data on oral beta-2 agonists.
Yes, so clonidine, beta-2.
Or beta-2 agonists, beta-2 agonists, oral beta. I know it's no controlled trials, but it's in the chapters, right? Yeah. Can I just say
sometimes-
one thing about
Yes.
transmission, just for people to
Yes.
remember that the commonest nosocomial respiratory infection is RSV. So
Yes.
pertussis, all very well, but remember your kids with RSV now, and your nursing staff and doctor staff and other people who may be infected. RSV is the commonest nosocomial infection currently.
So that's why we need the vaccine. Just want to see if there's anything else we should go through quickly, and then we're going to try end off in the next few minutes. I see, thank you. The panelists have answered quite a few questions. Would you suggest that fathers and other close contacts of newborns also get the Tdap booster? We're basically saying yes, aren't we?
So, it's nice to do that. It's not the most effective way of it's called the so-called cocooning strategy, right? If you could cover it, it's one of the most expensive, least cost-effective intervention to do so. And there are also very good reasons why not. It may take some time to develop immunity, and if the babies are going to get sick, it may be soon when they're young. That's why, to answer another question about asking whether it helps to vaccinate, to give vaccines when when you become a contact, it really does not help, especially if you have not been vaccinated before. Because, and maybe I need to just give this as basics. If you look at the studies done in the 1920s and 30s, Louis Sauer in Chicago, Theophilus Matson in the Faroe Islands, what became very clear when they were using whole cell pertussis was that you needed a large dose of bacteria to induce immunity. But if you use the whole dose, you got severe, terrible side effects. So they divided the dose into three. That's how we ended up with three doses for pertussis initially. It was not to try prime and boost. It was actually to try divide the dose that you needed to actually become immune. But you need that whole dose of 3 doses to actually be vaccinated against pertussis. And that's the reason why in pregnancy we're talking about this, which is a booster to a pregnant woman to get the antibodies up, because a child will not get all those doses in their early infancy before they actually have sufficient to have meaningful immunity against pertussis. And there's just no time. That is why even giving the birth dose that someone mentioned will not work, apart from poor immune responses against pertussis at that stage. So yeah, so you can cocoon. It's very good for the family to be vaccinated. It may go some way towards protection, but your real way of making any difference in a cost-effective manner is to vaccinate the pregnant mom.
Thank you. And then one question that's, I think, really important. I think Gabriel asked it. In terms of our suggested guidelines, or, in terms of admitting or which kids are at higher risk, do we say that all the less than 1-year-olds? Do we have an age that we know they're at higher risk? We know with pertussis before they're vaccinated, so the 3-month-olds, the 6-week-olds. Is there an age that we should be really very suspicious and most likely admit these patients?
If you're going to die, you're probably going to be less than 3 months or 2 months of age. It's just as simple as that, right? Whenever you look at all the data, you can die when you're 8 months old with severe pertussis, but the children most likely to die are going to be below 3 months and below 2 months of age, that age group. So those are the ones that are there. And you will probably, whether you make the diagnosis of pertussis or not, have a good reason for admitting them, like apnea, like cyanosis that is unexplained. So there would almost always be an indication for why you're going to need to admit them. But it's more so the case if you choose to do an investigation, like a full blood count with the differential, to see a relative lymphocytosis or an absolute lymphocytosis, as Charl mentioned before, of high cells. When that happens, you're probably already looking at part of what may be part of the definition of what is giving you fulminance in pertussis, and start worrying about severe pertussis that will be in trouble, if not now, but it's going to be in trouble soon and may need some kind of watching and monitoring. So That for me would be the case, but it's the age that is a major predictor of death for pertussis.
And remember for the PEDS registrars, because I see there's a few on, small children less than 6 months, especially when they get sick, they don't feed. There's a whole lot of signs. They don't feed. You could often see signs of distress. There's a whole lot of things, and you should have a really high index of suspicion of a viral infection that's going to lead to their demise. Shagan, do you want to ask anything else before we start closing off this wonderful session?
No, I think there's so many questions in the chat, and thankfully our panelists have addressed quite a few of them. And again, I appreciate all the people that have given us your time to attend our webinar, and thank you to our panelists. I just thought maybe, Despina, we could ask our panelists if there's any final comments or statements that you'd like us to take away.
Perfect. Let's go with Prof. Zah. Advice for the clinicians in respiratory season.
RSV is still the #1 pathogen, and same age group is the highest risk, under 3 months for hospitalization, under 3 months for deaths. A lot of deaths in low middle income countries outside hospital. We really have to push hard for prevention, which is now possible.
Thank you. Rudzani?
I would say when we looked here at Red Cross, 90% of cases we diagnosed with pertussis were missed by clinicians. When we did the study, if you're going to worry about pertussis, especially if it happened to be in a non-outbreak season, you have to think about it. If you don't think about it, you will miss pertussis. If things don't make sense or whatever, think about pertussis, ask questions. And if unsure, do a PCR. That's basically the way you're gonna diagnose it. Yeah.
Thank you. Charl?
Yeah, viral and any LRTI is still the most common cause of mortality in children outside of the neonatal period. And whether it's RSV, which has a very high morbidity rate, slightly lower mortality rate than some of the older infections, we have a lot of immunizations that can decrease LRTIs. We have a lot of things we can do to decrease the number of LRTIs and the mortality from LRTIs. And the future looks good for RSV, as Heather has mentioned. There's a lot of things in the pipeline. The future looks good. So if we can get rid of this one, maybe the wards will be a bit quieter for the next for a few months every year. And we can only hope that that will come to fruition.
Thank you. And so a last message to all the pediatricians and registrars on this webinar is, remember, we are the advocates. So we are definitely the advocates for our patients, and we should be advocating vaccines. There is a lot of hesitancy after COVID. I saw it was mentioned in one of the chats, but we need to be those advocates. And whether it be the obstetrician that you work with to remind them, or the microbiologist or the nursing managers that need to vaccinate the nurses, we need to advocate for these children. And so I ask you, SAPA will probably come out with something to assist in trying to get the RSV vaccine done. So please be the advocates where you work. Even if it's whether it be your child's school or the work where you work, your hospital, just be the advocates. And I do want to thank my co-host Shagan, Marti, for always organizing a wonderful webinar, and to our 3 panelists, Charl, Rudzani, and Prof. Zah. You're amazing. Thank you to everyone for listening and for all the questions. Obviously, we'll provide this recording ASAP. So thank you, everyone, and have a good evening. Thank you, guys.
Thanks very much.
Thank you,
everyone.
Thank you.